So in this short lectorial, we're going to go over some topics related to testis pathology. Just to remind yourself about the basic histologic structure of the testis. It's made up of a large number of these seminiferous tubules, which are surrounded here by basement membrane. And between the tubules and the interstitium, we've got these collections of these larger pink cells. And these are the Leydig cells producing testosterone. So what's going on in each of So a closer look at what's going on in each of these tubules. So you recall sitting around the outside against the basement membrane, we've got the undifferentiated germ cells, which are also called the spermatogonia. These go through a process of division and maturation in the tubule as they move into the center. The germ cells mature through a spermatocytic phase, and the spermatocytes we often recognize by this very sort of skein-like chromatin. They differentiate then into the smaller spermatids and then eventually into a spermatozoa. And there's a second population of non-germ cells, the Sertoli cells, which are designed to hold the maturing germ cell elements together and encourage their maturation from immature through to mature germ cell elements. Again, here's these Leydig cells in the interstitium that are associated with the androgen production. Remind yourself that the testis, like the ovary, begins embryologic life high up in the abdomen in the urogenital ridge. In the male, it is the Wolffian duct that matures, and it is the Mullerian system, which in the female would produce the uterus and tubes that atrophies. So the Wolffian duct system then goes on to produce aspects of the cord and prostate. And the testis develops high up in the abdomen, and during embryologic life is kind of dragged down into its definitive position with the help of the gubernaculum, which contracts and brings the testis first intra-abdominally, then through the process vaginalis into the scrotal setting. And so this transfer from abdomen into the scrotum usually occurs just before birth. So in most newborns, the testis will be in its definitive position in the scrotum. So this brings us on to the important discussion of cryptorchidism. And because that testis is descending abdominally and then through the inguinal canal and into the scrotum, there is potential for that descent to go wrong at certain points. And so cryptorchid testes are those that are stuck somewhere along that descent path. Most commonly they're held up in the inguinal canal. A small portion, 1 in 10, remain in the abdominal cavity, and some vanish altogether and really can't be identified. And so this is identified obviously at birth, where one or both testes can't be palpated in the scrotum sac. Why are we interested in this? Well, because we know that for normal germ cell maturation, the testes need to be at a lower temperature than the normal body temperature, hence the function of the scrotal sac. But if the testis is retained intra-abdominally or in the inguinal canal, then the testis is at much higher body temperature, and so we get dysmorphic changes occurring within the germ cells. Here's a cryptorchid testis that's been removed from a teenager, and we can see that all we're left within the seminiferous tubules here are the Sertoli cells, those supporting cells only. All of the germ cell elements have gone. Here's another cryptorchid testis, and this time we can see that the germ cell elements, the undifferentiated ones that sit around the outside of the tubule here, are really enlarged and very abnormal. And this is the precursor for a germ cell tumor. And so cryptorchidism increases the risk of testicular cancer by up to 10 times. Now, the testis can be the site for a range of infectious diseases. These can present as a painful mass or swelling, or would be associated with systemic symptomatology. In the absence of pain, then the testicular mass can be mistaken for a neoplasm. Many of the organisms that involve the testis or the paratesticular tissues are derived from organisms associated with urinary tract infections or with sexually transmitted infections. Interestingly, the testis and the epididymis are common sites for involvement by secondary tuberculosis, and the image at the top there demonstrates a epididymal involvement by tuberculosis. Viruses may occasionally involve the testis. The most common, of course, is mumps or chitis, and this particularly occurs when adults get mumps infection, and you get a lot of testicular swelling. This can be associated with testicular atrophy and even with infertility. A surgical emergency that involves the testis is the situation of torsion of the testis. So the testis hangs in the scrotal sac by a pedicle, and in certain individuals the testis isn't properly fixed inside the scrotal sac and is able to twist around on its pedicle. So this produces hemorrhagic infarction of the testis. So these people present acutely unwell with vomiting and with severe pain. So these are usually people under the age of 18, although occasional adult cases occur, and this is sort of bimodal distribution with neonates and males at puberty. So clearly, if the twisting is unable to be undone in time, then the testis undergoes hemorrhagic infarction and needs to be removed. So the picture shows such a case. You can actually see the twisting of the cord as shown there by the big blue arrow. The surgeon there holds the hemorrhagic testis. If the testis is still viable and doesn't need to be removed, then it is fixed back into the scrotal sac in place, and usually it's necessary to hitch down the other side as well, because that's also at risk of undergoing torsion. So for the rest of this presentation, I want to concentrate on germ cell tumours of the testis. So these are by far and away the most common neoplasm of the testis, and so you need to know a little bit about these tumours. So unlike most forms of neoplasia, which tend to occur in older individuals, germ cell tumours of the testis are interesting because they occur some in paediatric age range, but mostly they're involving young adult males. So the usual age range is sort of the 20 to 50, with a peak at about in the early 30s. As we'll come on to talk about, there are two sort of major groups of these germ cell tumours, the seminomas and the non-seminomatous germ cell tumours. The seminomas occur slightly older, about 10 years older, so that's the 35 to 45-year-old age group, and the non-seminomatous ones, as I say, in slightly younger people, often in their 20s. So these tumours present with usually a unilateral, painless testicular mass. Very rarely some of the tumours are associated with the steroid production, and so there is the odd presentation with extra testicular manifestations, and unfortunately a few of these patients present with metastasis as the first manifestation of their tumours. Because these are tumours of germ cells which are primitive in nature, they're often associated with the production of a range of oncofetal type tumour markers that can be measured in the serum to help diagnose and monitor these tumours. So the epidemiology of germ cell tumours is interesting, and here in New Zealand we're one of the countries, along with some other European countries, that have the world's highest incidence of germ cell tumours of the testis. And what's been fascinating is the incidence of germ cell tumours of the testis has been steadily rising over the past 50 years. So germ cell tumours of the testis are one of the tumours that have quite a strong association with genetics, and there's quite a sort of family predisposition to germ cell tumours. Also, people who have germ cell tumours tend to have subfertility or infertility, and so often these tumours can be turned up in investigation for infertility, or subfertility or infertility can be quite an important marker to predisposition for these germ cell tumours. We've already talked about cryptorchidism and the association of how descended or undescended testis and the risk of developing of germ cell tumours. So there's been a lot of interest to try and explain why there's been this rising incidence of testicular tumours. It doesn't appear to be a detection problem. We've not got a screening program or anything for germ cell tumours. A lot of people have related it to changing fashion, the use of more tight-fitting underwear or tight-fitting jeans or what have you, that bring the testes closer to the trunk, raising the testicular temperature. There's been studies which have linked it to hot tub use, and all sorts of interesting theories have abounded to explain this quite dramatic increase in testicular tumours. So as with a whole lot of different types of malignancy, germ cell tumours are associated with a non-invasive or in situ component. We call this germ cell neoplasia in situ. If you look at the image at the top, down the bottom right there is a more normal appearing tubule in profile. The other tubules there are abnormal, and they've lost the normal spermatogenic process, and you can see the germ cells, which have been highlighted there by a big red arrow, are quite abnormal. The nuclei are really dark and scalloped in appearance. If you look at the image down below there on the bottom left, again the arrow highlights some of these very abnormal germ cells, and this is what we call germ cell neoplasia in situ. It's often associated with microcalcifications that occur inside the tubule, and the blue arrow there marks one of those microcalcifications. These microcalcifications can show up on ultrasound, And you can see an ultrasound picture there showing this kind of snowstorm appearance of these little microcalcifications in the testis. And this can be a very useful way for screening, say, patients who come from a family where there's a high risk of germ cell neoplasia in situ, of germ cell neoplasia, to identify those individuals who may have germ cell neoplasia in situ. So in this image we can see, if you look at the tubule in the top left there, we've got a tubule showing the changes of this germ cell neoplasia in situ. Eventually these abnormal germ cells can proliferate, and you can see the tubules in the center, and then down the bottom right there shows the tubule that's beginning to fill up with what we call intratubular seminoma. This hasn't invaded yet, but is on the way to invasion. So the germ cell tumours largely derive out of germ cell neoplasia in situ, and as I said, we tend to have two sort of major groups of these. The first is the seminoma, the seminomatous germ cell tumours, and the second group is the non-seminomatous. So the seminomas tend to be more pure in their type. The non-seminomatous tumours are often a mixture of a range of different, more kind of primitive elements. So they may be made up of teratoma. So what we mean by teratomatous elements are either mature or immature tissues from a whole range of types. There might be mature or immature skin, mature or immature epithelium, immature cartilage, bone, neural tissue and the like. There might be components that recapitulate the embryologic yolk sac. Sometimes it is just pure malignant epithelial structures, and we just call that embryonal carcinoma. And sometimes it recapitulates trophoblastic tissue that is associated with formation of the placenta, and that we call choriocarcinoma. So the non-seminomatous tumours are usually made up of some sort of mixture of those more primitive elements. So this is the seminoma. So say this is a more homogeneous tumour. So seminoma is usually occurring in that sort of 35 to 45-year-old age group, and this represents the most common type of testicular germ cell tumours. So again, as with all of these, it usually is a painless testicular mass, and often you can tell when you cut the specimen that you're dealing with seminoma, because it has this sort of vague lobulated appearance and this rather sort of homogeneous pale light pink in colour. Down the microscope we have these nests of tumour cells that look not unlike the dysplastic germ cells and germ cell neoplasia in situ. They're rather round or polygonal cells, and they have quite a lot of cytoplasm. And what's often characteristic is in these tumours they sit in nests, and there are cords between the cells with lots of lymphocytes and plasma cells. So seminoma has the best prognosis of the germ cell tumours, and for early stage tumours that haven't spread beyond the testis, cure rates are 98 or 99%. So seminomas are exquisitely radiosensitive, and so if there is spread into the retroperitoneum, then that can often be sterilised with radiotherapy. Or for more advanced diseases, they're also very chemosensitive. So you've got some pictures of a non-seminomatous germ cell tumour. As I say, these are often mixed with a variety of patterns. So that teratomatous component, we've got a whole mixture of relatively primitive epithelial and mesenchymal elements, but we can still sort of recognise vaguely what the embryologic structures are. whereas they're often mixed with embryonal carcinoma, which you can see on the right there. And so this is just, undifferentiated high-grade unpleasant malignancy. So the non-seminomatous germ cell tumours, as we see it occur, perhaps slightly younger than the seminoma, and are more commonly a mixed pattern. As we can see in the picture there at the top, compared to the seminoma, these often have a very heterogeneous appearance. There's areas of necrosis, hemorrhage, and the like. These don't do quite as well as the seminomatous components. They tend to present as at a higher stage, and their prognosis really depends often on how much of the bad component, that embryonal carcinoma component, that they've got in them. They are again chemo and radiosensitive, but for higher stage disease, survival tends to drop off a little. Okay, thank you.